All right, hi everybody. Just wanted to welcome you to tonight's webinar. My name is Darren Schumacher. I'm the Director of Marketing and Business Development at OSMS. And tonight, Dr. Abby DeBruin, will be talking about common knee injury in male athletes. So a couple just housekeeping things is we are recording this webinar, so I want to make you aware of that. And then the finished recording of the entire webinar will be on our website at osmsgb.com/webinars by the end of the week, probably on Friday. If you have a question for Dr. DeBruin, please leave it in the Q&A box. And after Dr. DeBruin is done with her presentation, he will be answering your questions. And before I turn it over to Dr. DeBruin, I just wanted to mention that Dr. DeBruin is the only female orthopedic surgeon in northeastern Wisconsin with a sports medicine fellowship. She'll talk a little bit more about her background. And with that, then I am going to turn it over to Dr. DeBruin to talk tonight about common knee injuries in female athletes.
Awesome, Darren. Thank you. Hi, everybody. Abby DeBruin. I'm just here to kind of give you all a little bit of an overview. So I'm going to share my slides here, and we'll kind of go over an overview of some of these common injuries. And then from there, we'll have lots of time that's left open for questions, because I know sometimes that's the most useful part. So let me just get this set up. Perfect. Darren, did you want to go over a little bit of intro about OSMS before we kind of delve in?
Yeah, that's a great point. I'm going to just go over the first couple slides here. So just to talk a little bit about OSMS. So if you're not familiar with us, we are a doctor-owned orthopedic sports medicine, rheumatology, and pain management practice. You can see our locations. So we have multiple locations throughout northeastern Wisconsin. We also have a number of orthopedic doctors. We're the largest rheumatology practice in the state, as well as having pain management physicians. One thing I wanted to note is with the number of orthopedic physicians we have, we really pride ourselves on access. So if you can usually get an appointment, if not the same day, typically the next day, and we'll be able to do if you're in pain or have any kind of injury, the last thing we want to do is wait a long time to be seen, and we can definitely see people in a fairly quick amount of time. For the next slide here, we're going to...
Sorry, I promise I'm trying.
One of the things we have is we have a full range of services all in one location. So in our OSMS clinics, like in Green Bay and Neenah, X-ray, MRI, CT scan, we actually have bone density as well within those clinic locations that can be done. And then again, full range of services in one location. We do infusion services on the rheumatology side of the business. We do have 2 surgery centers that specialize in only in outpatient orthopedic procedures. And I do want to do a little bragging about that is our surgery centers have been named one of the best in America for the 3rd year in a row. So we are the only surgery center in Green Bay to be named that. We are the only surgery center in northeastern Wisconsin to receive being named one of America's best surgery centers 3 straight years by Newsweek. So we're very proud of that. We do have a walk-in injury clinic in Neenah and in Green Bay. So Monday through Friday, we have in Green Bay, we're open until 7 p.m. Monday through Thursday. In Neenah, we are open through until 7 p.m. on select weeknights. Look at our locations page to know which nights we are open. But the walk-in clinic is also open. The differentiator with our walk-in clinic is that you're seen by a physician without that appointment. And you're thinking, oh, that sounds expensive, but actually we charge it as a regular office visit. So we don't add an emergency or urgent upcharge. Even though you're walking in without an appointment for a new pain or injury, we charge it as if you did have an appointment. So it's a great satisfier, and it's a great way to get your treatment plan, get your diagnosis right away with our specialists. And then we do have physical and occupational therapy partners in our clinic locations as well. And then last, I did talk a little bit about extended hours. So whether you're making an appointment or walking in, again, in Green Bay, we are open until 7 p.m. Monday through Thursday, and then 8 to 5 on Friday. In our Fox Valley Clinic in Neenah, It switches every other week. So one week it's Monday, Tuesday. The next week it's Wednesday, Thursday until 7 p.m. And then just again, look at our webpage for the location or on the locations page for details of when, which days we are open in the Fox Valley until 7. Now I believe with that, oh, one last thing, I'm sorry. Since our walk-in clinic isn't open 24 hours, we do have a free chat program called Ortho Access. So anyone can get free advice from an orthopedic expert 24/7 for free via our free chat program called Ortho Access. So you're guaranteed to get a response within 5 minutes. Now it's not an appointment, but it is advice, and it might tell you, should I walk in? Should I make an appointment? Should I just rest and ice something? And it can give you peace of mind before you take action and kind of give you some advice on what that next action step should be. And there's no app to download. It's all web-based. So we're not asking you to download anything. And you can also share pictures. So if you see bruising or swelling, you can share that with the orthopedic expert as well.
All right, so I'm going to get started. A little bit of background about myself, and then we'll kind of breeze through some of these slides so that there's plenty of time for anybody to ask questions, and we'll go from there. Also, feel free if we're kind of going over a topic that is interesting to you or you have a question about, feel free to just go ahead and turn your microphone on and ask me a question or type it into the chat. And Darren will try to remind me if we get any questions that are popping up. We can try to answer them as we go as well. I'm okay with anything. So I'm from this area. I grew up in Sherwood, Wisconsin, and I went to Kaukauna High School. I played basketball and volleyball there. And I played basketball at Northern Michigan University up in the UP. So got out of Wisconsin for a little bit. And then I was back down in Madison for med school and my orthopedic surgery residency. And then after that, I did a sports medicine fellowship at UVA in Virginia. I took care of the James Madison football team down there, as well as the UVA basketball and lacrosse teams. So definitely a lot of experience taking care of high-level athletes, and really have great mentors and really great sports experience there. And so that's definitely, one of my main passions in orthopedic surgery is taking care of athletes, and specifically, female athletes. I've been through ACL tears and surgeries myself. And so that was one of my motivations to go into this field. And I really enjoy being able to help other athletes kind of get back to the things that they want to do, like I was able to do. But I also enjoy, just being home back in this area and being able to kind of take care of anyone in this community. So I would say generally my kind of clinical interests are mostly shoulder and knee, and I do everything from, the arthroscopic and the more complicated sports surgeries like cartilage surgeries, osteotomies, things like that, all the way through joint replacements in both the knee and the shoulder. So just for kind of a basis of this talk, what I did was looked at a more recent study of professional female soccer players. Now, different sports have, somewhat different statistics, but just to kind of have an overview of some of the common injuries that female athletes see in the knee. The percentages here are kind of the percent of the injuries reported in this group of these high-level female athletes. And then I added some additional ones. So I think some of these are the injuries that we'll kind of go over, and I have a couple slides for each. So again, this is a point where if there's a specific question on one of these issues, feel free to bring it up while we're talking about it. Otherwise, of course, we all have time for questions at the end as well. Okay, so hamstring strain, hamstring and quad strain are probably the most common reported injuries in athletes, but a very low amount of, missed time from these, or at least lower than some of the larger injuries. And oftentimes these are things that we can treat without surgery. So again, hamstring strain being very common in both female and male athletes, up to 30% of lower extremity injuries in different publications. And then there's kind of a photo here. I'm not sure if anyone can see my mouse or not, but there's multiple different locations where hamstring injuries can occur. So the hamstring kind of attaches kind of up in like the buttock area on your ischium, and then it extends, and the majority of the hamstrings attach on the medial knee. So it actually crosses both the hip and the knee. And so some of the distal hamstring injuries can be noted at the knee, and that's why I included it in this talk. The myotendinous junction, which is the area kind of up here, if you can see my mouse that I'm kind of highlighting, is one of the most common areas. And then just kind of the muscle belly, like the back of the thigh, is very common as well. So these are common in rapid acceleration sports. And then water skiing is another big one that I tend to see. A lot of our patients with these injuries present with posterior thigh pain, bruising. Oftentimes we can just treat these with rest, ice, anti-inflammatory medications, maybe some protected weight bearing in the early period. But kind of the issue with these is that the area of previous injury can lead to some scar tissue formation and an area of the muscle or the tendon that's at somewhat increased risk of re-injury. So for people who have had issues with this, stretching and a really strong kind of warm-up program is really important, because these can be a little bit of lingering injuries if people aren't kind of taking appropriate care of that. So again, inappropriate warm-up, and then strength and balance between the quads and the hamstrings can definitely be at play in this as well. And I would say that's a topic that comes up a lot in female athletes. So it comes up in our ACL conversations, just kind of our different muscular patterns. And so that's something that we'll continue to talk about. The more proximal hamstring injuries, so right off of that ischium or that butt or sits bone, those type of injuries can occasionally require surgery. So if people are having a lot of posterior thigh pain, but also pain in the buttock area and a lot of pain with sitting, those are injuries where I would recommend evaluation on the sooner side. Oftentimes I'll get an MRI more quickly for those more proximal injuries to take a good look at where the tendons are attaching to the bone. If there's 3 total hamstring tendons, if all 3 of them are pulled off of the bone, or if they're retracted more than 2 centimeters, those are kind of our guidelines for talking about potentially doing surgical fixation. So that's what this picture in the bottom is demonstrating, when all 3 of those tendons, and it's kind of depicted all in one here, but when they're pulled off of this bone, we sometimes talk about doing a surgery to reattach those. So I would say hamstring injuries that are higher up, which I know is getting away from the knee, but those would be ones to kind of seek evaluation for on the sooner side. Okay, so moving on to another really common one in that study of the professional female athletes, meniscus injury was, a higher incidence above ACL and some of the other injuries that can require more missed time, but these are sometimes more frequent. So as an overview, for anyone out there who's less aware of this, the meniscus is kind of the shock absorbing tissue that's in between your femur and your tibia, so kind of in the knee joint. So if you can see my mouse, that would be this kind of C-shaped ring here and here, and it's kind of like a cartilage-like material. And then I included an arthroscopic photo because I think, as orthopedic surgeons, we are really interested in these, but I think patients and other people are interested in kind of seeing what does this actually look like as well. And so over in the corner here, you can see the femur and the tibia, and then the meniscus is this kind of like stripe of tissue. And this is essentially a shock absorber in the knee, and it helps to decrease point loading. And so it can also be a secondary stabilizer, but essentially this is some of the shock absorbing tissue in the knee. And so tears or injuries with this can lead to kind of increased loading in that area of the knee. And that's why, it's important to address them. So the peripheral edges of the meniscus, for example, out in this area, they get really good blood supply from the capsule. And then the more intra-articular or free edge, we call it, sections of the meniscus, they don't get as good of blood supply. And so the healing ability is less in those locations. And that's why a lot of you out there may have heard of people who've had like a partial meniscectomy or trimming of the meniscus, because certain tears of the meniscus are just not amenable to healing, but certain tears are. So there's lots of different types of meniscus tears. Again, this is kind of showing some depictions of what the normal meniscus looks like. And if this attachment, normally it's the posterior root, we call it, or the attachment down to the bone, is torn in a meniscus, then essentially the whole meniscus isn't able to provide its usual function with weight bearing as the femur and tibia come together here. If the root is torn, the meniscus can kind of squish out. And so that would be a type of meniscus tear that we would talk about, surgery for to fix. And then some of these more peripheral tears, like this example that says longitudinal tear, some bucket handle tears, would be ones that would have appropriate blood supply in certain cases to heal. And so those ones we might talk about fixing. certain like flap or degenerative tears, like these bottom examples, would be ones that are in the area of the meniscus with poor blood supply and poor ability to heal. So some of those are ones that if they're causing people symptoms, we would need to trim out. Now for our athletes, a surgery where we do a partial meniscectomy or trimming of the meniscus means relatively quick return to play, mostly based on incision healing and management of swelling and then their rehabilitation. But oftentimes we can get people back quite quickly after those types of procedures. And the kind of symptoms that patients would have with meniscal tears would be, increased pain at the joint line, and then oftentimes some sort of like clicking, catching type feeling, even locking sometimes where the knee gets kind of stuck and isn't able to fully extend or to bend past a certain point. All those can be signs of this. So that would be a reason to, go in and have somebody get looked at, and likely get an MRI is the main way of how we diagnose these. So this was one example of that root tear that I was mentioning, just kind of at that attachment. So you can imagine if there's a tear here, that meniscus can just squish out. And so we would need to repair that back down to the area that it came from. So again, I think I kind of touched on the treatment already. I like to share these arthroscopic photos so that you guys can get an example of like what we're actually looking at. So a lot of types of these tears are ones that we would have to just trim. So this is an example from one of my patients on the far left of the screen, where my mouse is. If you can see that again, of just a portion of that meniscus tissue that's kind of torn and flapping out into the joint. And so as the patient is walking, when that gets stuck in the joint, it's almost like walking with a pebble in your shoe, but instead of in your shoe, it's inside of your knee. And so you can imagine that would be quite irritating. And so for that, we just trimmed that part out. And so then you can see this picture here in the middle. It looks a lot like that normal arthroscopic photo of the meniscus that I showed you earlier. We still have the femur, the tibia, and then this is healthy meniscus that we've trimmed back to. So we try to keep as much meniscus tissue as we possibly can, because again, the healthy meniscus tissue is shock absorbing tissue inside of the knee. But that torn piece obviously wasn't serving this patient any longer. And so we got rid of that to take care of the symptoms they were having. And then the picture on the far right corner is one of my recent patients who had had a more peripheral meniscus tear in a young female athlete, a volleyball player. And so you can just barely see, I'm like ducking because my screen is a little darker, but you can just barely see some stitches in that meniscus tissue, and then my probe kind of showing it to you. But essentially that was a more peripheral meniscus tear that we were able to repair with sutures. And hopefully that tear will go on to heal. There's, higher rates of healing in our young, healthy patients on those peripheral type tears. And that way they get to keep all of that meniscus tissue, all of that shock absorbing tissue, and we, avoid having to trim it out. So a little bit of a case by case basis with those, but a very common injury and lots of different variations of it. All right. So I know I'm going through this somewhat quickly, but I think a general overview in a way of some of these topics is great, and it can foster some, further discussion. So we'll move on to MCL injuries, another very common injury, especially in contact sports. These are seen a lot more often with contact to the outside of the leg. And what that does is causes the knee to kind of bend inward. And when that happens, the MCL is the ligament on the inside of the knee that gets stretched out and can get either strained or torn. So in this photo on the bottom, this is a great example. You see this US soccer player is getting the outside of her knee hit. It's causing the knee to bend inward and causing stress on the MCL. So what we see is pain on the inside of the knee or the medial part of the knee, laxity on exam, and that's something that athletic trainers, see very commonly. It's a very common football injury as well. So a lot of our athletic trainers are, very attuned to picking these up. But laxity on exam, and oftentimes in our athletes, we obtain an MRI to evaluate kind of the grade and location of these tears. So just as a brief overview, these are some MRI cuts of MCL injuries. So more proximal MCL injuries are definitely the most common that I see. And so this top picture here is showing on the inside of the knee up here in this area where I'm kind of circling with my mouse, that you have this increased signal. And then the more healthy MCL tissue is this nice discrete black line that's coming down. Those are definitely the most common place that we see MCL injuries, and there's a very high rate of healing without any, residual laxity or problems without surgery with those types of injuries. Oftentimes we're talking about bracing for those, and reasonably quick return to play for a lot of athletes with those kinds of injuries. The more distal ones can be the more problematic MCL tears, and we tend to see the more distal tears with higher energy trauma. So sometimes this might be, like a car or a scooter accident, or just a, really significant collision and a sports injury. We can also see MCL injuries relatively commonly along with ACL injuries. And sometimes we talk about, needing to address those if we're doing a surgery for another part of the knee. But this picture here on the bottom is showing a distal MCL tear. So you can see that there's a lot more trauma, a lot more edema or swelling in this picture as compared to the one up above. So in this picture, the proximal MCL off the femur is intact up here, and you can trace it down, and then it kind of turns into like a rubber band, like it got snapped back up, and this distal part is torn off. The issue with these distal tears is that the hamstring tendons, like we've already talked about, come in and attach medially. And if the distal MCL tears and kind of springs upward like a rubber band, those hamstring tendons can actually get interposed between the distal MCL and the bone where it's supposed to heal. And then that prevents that MCL tissue from kind of scarring in and healing. And so these are ones where we would need to do surgery to get that MCL back in the right position, repair it, and allow it to heal, excuse me. So again, most of these MCL injuries we can treat without surgery. We'll do a hinge knee brace, some rest, and then physical therapy. And for the lower grade injuries, we're talking a couple weeks to return to play, and higher grade injuries, up to a couple months. But that's a lot of it is based upon stability on exam, but also how the athlete is rehabilitating. And again, surgical repair would be pretty much reserved for the distal tears or potentially in combination with surgery for additional injuries. All right, so ACL tear is definitely, I would say, the hot topic for our female athletes. There's probably upwards or even more than 400,000 ACL reconstructions done every year in the United States alone. So this is a common injury, and then it's increasingly more common in females compared to male athletes. So anywhere between 4 and 6 times more common for female athletes to have this problem as compared to males, depending on the literature that you're reviewing. These are often caused by non-contact or what we call pivoting injuries. And these definitely cause the most missed time from sport. So again, this was only a couple percentage of that study of professional female athletes, but definitely the injury that caused the most missed time. So this is definitely a hot topic in female athletes. Female soccer and basketball players are probably the most common. Sorry, and I was just going to review kind of the anatomy. Is the ACL is this ligament here. It's in the middle of the knee or in the notch of the knee. So if people have an injury to this, they often have a difficult time describing, a specific location. They just kind of say, it feels like my knee or deep in my knee. And what happens is that ligament is the restraint that keeps the tibia from going forward or anterior on the femur. And so when this injury happens and the ACL ruptures, it tends to kind of explode, like these two arthroscopic photos from different patients of mine that I've shared at the bottom. And you can imagine that attempting to kind of repair those mop ends is not ideal. And people have tried that in the past and the results are poor. And so that's the reason why with ACL tears, we have to do a reconstruction surgery. So just a couple other things to highlight with ACL tears. There's a lot of reasons why we have found and why we think women get these injuries so much more frequently than men. But I would say a couple of the leading factors are biomechanics and anatomy. So what we call the Q angle, meaning the kind of hip, knee, ankle alignment in females tends to be a little bit wider hip and then going, more inward to the knee, which can affect landing biomechanics, but then also the neuromuscular kind of patterns that women have, or female athletes, especially like the high school female athlete compared to males, are quite different. And so the female athlete tends to have a little bit more of what we call a hip adduction and a knee valgus motion. Essentially what that means is the leg collapses inward on landing, and that can put the knee in positions of increased stress, especially on the ACL and other ligaments in the knee. The other thing is that hormones even can affect this. So estrogen causes increased ligamentous laxity. So as someone is kind of going through their cycle, they'll have certain times where they're potentially at increased injury risk because of even their hormones. So there's a ton of different reasons why females are more prone to these injuries. And they're obviously very serious sports injuries. So I think it's definitely an important topic for female athletes. Again, we can see meniscus injuries. It's pretty common to see meniscus injuries, oftentimes peripheral ones, along with ACL tears and MCL injuries as well. Oftentimes lower grade ones that don't, require surgery, but something to note. So essentially, the surgical treatment for an ACL tear almost always requires a reconstruction. Now, certainly there are some people who are, finished with their athletics and of a certain age where they might attempt to go without surgery, but the vast majority of patients, and especially athletes, would require a reconstruction for their ACL tear. And the reason for that is that without that stability in the knee, attempting to return to athletic activities, cutting, pivoting, deceleration, all of those things put the secondary stabilizers, or the meniscus, and the cartilage in the knee at risk. So if you're participating in athletic activities without a functional ACL, you're at very high risk of an injury that could be catastrophic to the knee, a really severe meniscal injury, or even a cartilage injury, which, we have some limited treatment options for, but sometimes devastating, these kind of second hit injuries if somebody has an unstable knee. So that's why it's so important that we obviously identify these and treat them appropriately. The treatment for this could be a whole talk in and of itself. There's a lot of different graft options that are out there. I would say patellar tendon, or using the middle third of a patient's own patellar tendon, is pretty much the gold standard across the orthopedic literature. And quad tendon has become a lot more popular even over the course of the last 5 years, and has quite good data and very low failure rates, similar to BTB. Hamstring grafts are one of the big, former workhorse grafts that I would say we're starting to see fall out of favor just a little bit. So a recent study that was published by the Moon Group showed a slightly increased risk of failure or re-tear with hamstring grafts, specifically in female athletes, specifically soccer players. But those are some of our, the most common people who get these injuries. So I would say most, more recently fellowship trained orthopedic surgeons are really starting to lean away from the hamstring graft. And even in, the athletes in their 30s or 40s, the quad graft is a really nice option that has, low risk of anterior knee pain, very good stability, very low re-tear risk. So that's something that we have a discussion with every athlete kind of about their specifics of their sport, right? So athletes that are spending time on their knees as part of their sport, like a volleyball libero, a hockey goalie, a wrestler, those would be people who a quad graft might be a better first option for than patellar tendon. But for the most part, my high school and college athletes, a patellar tendon graft is my first choice. And that type of graft has a bone plug from both the tibia and the patella, which get plugged into kind of sockets that we create in the femur and the tibia to recreate a new ACL. And I think that bone-to-bone healing is a really important factor. For return to sport, this is a tough part of these injuries. It's essentially a 9-month to a 1-year return to sport in high-level athletes. That's what we're seeing in, professional and college athletes. I would say 6 months would be an absolute minimum, but our studies have shown us that attempting to return to sport too early can put the person at significant risk of re-injury. And that's because we know that at a certain point, probably around 3-4 months, when the athlete might be starting to feel overall very good and want to push and progress, the graft has not yet been incorporated by the body. So the body reconstitutes that graft with, new cells, and that process hasn't happened yet. So the graft is actually at its biomechanical weakest point at that 3-4 month period. And so people who try to push, early return to sport are at increased risk of re-injury. So that's why this takes such a long time. And then, as we kind of talked about some of the risk factors like the landing mechanics, and strength, those things really play a role in when an athlete is ready to return to sport after an ACL surgery. And so we generally are doing testing with physical therapy, every couple of months to help determine when they might be ready to return to sport, as well as, of course, a progression of return to sport activity. Okay, that was pretty quick to go over a pretty big topic. We'll definitely have time for questions at the end, so I'll just keep kind of blowing through these slides. I think I'm doing okay on time, Darren. Okay, I'll wrap it. I'll speed it up a little bit. Okay, so patellofemoral instability. This is kind of the other big topic that I wanted to hit on because it is more common in female athletes than male athletes as well. Females tend to have an increased risk of hyperlaxity as compared to males, and that's a risk factor for this. But what patellofemoral instability means is essentially a kneecap either dislocates, and they generally dislocate laterally or out the side, or has an instability event but kind of pops back in on its own. And there's a medial ligament to the patella called the MPFL. Oftentimes that's torn along with this dislocation event, and cartilage injuries are common along with this as well. And the problem with these is that they have a pretty high risk of recurrence without surgery, depending upon a person's anatomic risk factors. So this gets into a little bit of orthopedic nerd weeds, and I'll try to avoid that, but essentially how high the patella is, the shape of the trochlea, which is depicted in these photos down here, where instead of a nice groove, you almost have this like bump where the kneecap is articulating. The overall alignment of your patellar tendon to your kneecap to your quad tendon, and any malalignment in the limb. So these x-rays are examples showing a woman, this I think was like a 14-year-old girl, who you can just see from the hip to the knee to the ankle, her knees are kind of going inward. And we actually did a surgery to realign her distal femur so that her leg was straighter. That helped with her kneecap wanting to dislocate laterally. So all of these different things, along with ligamentous laxity, put someone at increased risk for this problem. And we see this a lot more commonly in females and female athletes as compared to males. So again, after a first-time dislocation, we can certainly treat this with bracing and physical therapy. But again, pending somebody's risk factors, we may talk to them about treating it more aggressively off the bat. And so surgeries that we do for this or that I do for this are MPFL reconstruction, which is pictured on the bottom, to kind of recreate that medial ligament to make a barrier for the patella wanting to dislocate laterally. But I also do osteotomies where I move the patellar tendon attachment, or femoral osteotomies like the picture on the last slide, to change people's anatomic risk factors to decrease their risk of recurrence of this problem when it's needed. A last thing to mention would be patellofemoral pain. This can be pretty common in our female athletes as well. And this is essentially just anterior knee pain without them having instability of their kneecap or any structural problems that we necessarily see. And it's likely due to just the quadriceps being weak. And so that leads to poor patellar tracking and pain associated with that. So generally it can be managed without surgery. Physical therapy is really the mainstay of treatment with that one, focusing specifically on VMO or quad strengthening, as well as some of the other modalities that athletic trainers often help our athletes with. But that can definitely be kind of just a flag of somebody who is strength is maybe not to the level that it needs to be for their sport. Cartilage injuries, again, we see these and we have treatment options, which I think are very interesting for specific ones, but I'll kind of blow through this a little bit quicker. There's a whole range of treatment options. This is a photo from a recent surgery that I did, implanting a new plug of cartilage in an area of a defect. And the last thing I'll touch on briefly are quad and patellar tendon ruptures. The quad and the patellar tendon are obviously part of our extensor mechanism. Without them, we can't extend the knee. So injuries to those, like complete ruptures, are more common in athletes in their 30s or 40s. They're essentially caused by when the quad contracts with the knee in a flex position. Can happen in jumping sports. Sometimes a patient just misses a step or something like that. And there can be some association with different inflammatory or autoimmune conditions that I've kind of listed here. And essentially, if there's a complete rupture of either the quad or the patellar tendon, you'll know because you won't be able to extend the knee. That's something to definitely get in and get evaluated for. They almost always require surgery in order to fix those, to restore that extensor mechanism. So those are kind of the broad strokes of a lot of different categories of knee injuries that I see in female athletes of different age ranges. So now that we're back at the questions slide, I think I did pretty good speeding up towards the end there. I don't want to keep anybody too long, and I want this to be able to be interactive. So I'm going to leave this and stop sharing.
Thank you.
Okay.
That was great. So if anyone does want to ask a question to Dr. DeBruin, please leave that in the Q&A part of the area just below on your screen. So please go ahead and do that. As you're doing that, we did have one question come in here that I want to so that is, do certain sports or activities put female athletes at a higher risk for knee injuries?
Yeah. So I would say the highest risk by the studies and by what I see are probably soccer and basketball for the big injuries like ACL tears in female athletes. Another one would be skiing as we're approaching the winter time. That activity does have some inherent risk. There's certainly ways to do it safely. I would never advocate for people to not do that if it's something that they enjoy. But those are some of the, I'd say probably top 3 for female athletes that I see.
Great, thank you very much. And again, if you have a question, go ahead and leave it in the chat. Oh, here we have a question that just popped up. So best exercises or weight training for ACL tear prevention?
Yeah, Mike. So that's a great question. And again, that could be another talk in and of itself, which maybe I can arrange with Darren in the future. But essentially, what I think of as the biggest things, and this is somewhat individualized. So I do think it's important for our athletes to essentially, potentially get some cross training, to get some evaluation, because most of our female athletes, I would say, are what we call quad dominant. Most female high school athletes, I would say, are quad dominant, meaning that the hamstrings are not as strong as their quad just because of what they're doing for their sport specific activities. And it tends to be that we're not focusing as much on cross training, strengthening, things like that, especially in the world of, club sports. There are high school athletes who are playing a sport year round, and then they're maybe not focusing on other strengthening type things. But I would say the most kind of standard picture would be a female high school athlete who is quad dominant, the hamstrings are a little bit weaker, and then they have a little bit of that kind of abduction or valgus moment of the leg with their landing mechanics. All of those things combined put them at increased risk. So I think for their strengthening and cross training, it's a lot of hamstring activities to try to catch those hamstrings up to the quads. But again, that can sometimes be personalized. There's been lots of different studies that have tried to look at like a specific ACL prevention program with X, Y, and Z exercises. And I would say mixed results on how the data shows those actually parsing out. So it's probably just the most important thing to be focusing on balance, strength, and good landing mechanics. And sometimes people need a little bit of assistance with that. I remember going through my own rehabilitation after ACL surgery and spending a lot of time like doing jump landing in front of a mirror with an athletic trainer that's kind of giving you feedback on those things and kind of learning like, what should this look like? What should I be focusing on? Because the more we can train when we're not involved in an active competition, the more that we can train those neuromuscular patterns, the better off we'll be. But that's not, sometimes easier said than done. So physical therapists and athletic trainers are great assets for this. And then I think, increasing our cross training and our strengthening in our high school athletes is probably important. And sometimes that's, again, not so easy for a high school athlete to incorporate in their routines. We do have some partners like Synergy that help with things like that. And then they have some expertise in kind of guiding some of these things. So I think, for those high level athletes that are looking at what can I really do for prevention, I think stuff like that can be a great option, even if it's just for a specific time period to get that expert advice, and then they help you craft a routine that works for you, and then you incorporate that you do it every day before practice or something like that. I think that's always a good idea. Okay, I see some more.
I was gonna say, we have more questions. So, do you talk to your female patients after ACL reconstruction about the re-tear rates?
I do.
and the rate of return to prior level of sport research. It's such a tough conversation.
Yes. Yeah, Ben. So I do always talk about that. I explain to patients that they have a risk of re-tearing their ACL graft, and they also have a risk of tearing the contralateral ACL. And it's easy for me to have that discussion because I've torn both my ACLs. So I can literally, if I'm wearing a dress or a skirt in clinic, I can just like show them my knees and be like, listen, this is a conversation that we need to have. Obviously, super important when a person is rehabbing after an ACL surgery to focus on both legs. And try to strengthen both of them and focus on their landing mechanics in both. But of course, there's, risk factors that we can't always, 100% control. And so I do bring that up. Interestingly, the Moon Group that put out some of the most recent literature that we have on ACL graft selection and, just overall information about this stuff has a really nice calculator right on their website. So I can share my screen and show anyone who's interested what that looks like at the end. But what I've actually started to do is to bring that up with my patients. Now, it doesn't say every single graft option, but my interpretation of the literature is that quad grafts are very similar failure rates to BTB grafts. And so this Moon calculator can show a patient, you enter their like height, weight, their sport, their age, and how often are they participating in cutting, pivoting, decel activities, which for most athletes, if they're attempting return to sport, it's going to be the max answer, which is 4 or more times per week. And that'll show you their re-tear rate of either a patellar tendon or a hamstring graft. And it also shows re-tear rate in the hyperlax individual. So a lot of these female athletes that have hyperlaxity, just even hyperextension on the contralateral knee, I'll kind of show them those numbers. And I think that kind of helps lay it out for the individual athlete. And they also have a contralateral ACL tear calculator. And so I don't always do that for every single person. I normally just say it's up to a 50% increased risk on the other side after you've had one of these injuries, especially a non-contact injury. But some people who are interested and data driven, I even show them that risk on that Moon calculator. So again, if you want to hang around at the end, I can share my screen and show that to you.
We have another question here. Andrew asked one. I had to ask just for a little bit more specifics.
Yeah.
So you definitely did that. So I appreciate that, Andrew. Good question here. So after surgery, what is recommended beyond physical therapy? It seems like a large gray area between post-surgical physical therapy and return to play.
Absolutely, Andrew. Yeah. So in my experience, I think that there's a need for what I would refer to as an ACL bridge program. And so what that means is, again, once somebody has kind of reached the point where they're kind of peaking what they're doing with their physical therapy in that setting, I think we need a little bit of a comprehensive program to help them get closer to return to sport and to start some early sport-like activities that are approved with appropriate guidance. And so I'm working a little bit on developing some of these more formally. This is something that I was involved in and I think is really important in high school athletes in my fellowship. We don't have a formal one here yet, but I'm going to work with our therapists at Advanced. We do have that partnership I mentioned with Synergy, and I think that would be an excellent location, somewhere where you're getting people into a little bit more of an athletic sport-like environment, but you would still have guidance from either a physical therapist, potentially an athletic trainer, but somebody who really understands kind of the protocols and where we're at in the phase of recovery. And you can also do that in a group setting. So I've seen this be really successful with high school athletes. You have a group of kids from a similar area, probably all different schools, but they're at a similar phase in their rehab, and they can get going on some early sport-like activities with appropriate guidance as they're transitioning from physical therapy to being able to get back to a full go in sport. I think that's a motivating environment, and it's also good to have that level of supervision as opposed to having them, on the sidelines of their practice, which they probably will do too. But, obviously less supervision and less kind of knowledge of what things are approved and not approved. So I think that that's another area where I want to see us develop something that's a little more formal and robust. Absolutely helpful, absolutely a need for it, and something that we're actively working on. So if there's any physical therapists or athletic trainers that are on the line that, have specific info of a really good bridge program or would want to be a part of one, let me and Darren know. We'd love to work with you. Okay, I see a question about graft options.
So the question from Katie is, which graft or grafts do you prefer to use for an ACL injury?
Yeah. So I would say essentially all of my ACL surgeries are either a patellar tendon, BTB, or quad tendon graft. I'm really not doing hamstring grafts just because I think we have other options that are as good, if not better. I don't think that's bad. There's certainly some literature out there and lots of patients who have done well with them. So it's no knock against surgeons who may do that. But in my hands, BTB, again, pretty much my gold standard choice in my high school, college competitive athletes. Quad tendon, also very good, maybe in my 30, 40-year-old, like more recreational athletes, but still very good data for that. And sometimes a first choice in a specific athlete, again, where I'm specifically wanting to avoid any anterior knee pain. That is a known risk with BTB, although I would say most of our athletes do very well with that. So those are my top two. Allograft is an option as well. I would say nobody in their right mind would be using that in an athlete and a young person. It can be considered in, older patients, maybe somebody in their 50s or 60s. I would still offer those people an autograft option because we have very strong literature showing higher failure rates in allografts, again, in patients under 30. So anyone who's quite active, I would certainly stay away from that, although it could be a reasonable option for certain people.
Here, this is a good one. Are there resources available for coaches to educate on being able to identify risky mechanics in athletes to help prevent ACL injury?
Yeah, gosh, you know what? I don't know of like one specific resource that I would send you to. So that's maybe a good question for me to investigate and see if I can find something great and follow up with you on it. I think overwhelmingly in female athletes, the thing that we see is that inward motion of the knee with jump landing. That's probably the easiest way to describe it. So in the textbooks or in the literature, it's going to talk about hip adduction, ADD adduction, and knee valgus. But what that looks like is just an athlete whose knee is kind of caving in as they land. And I'm sure you all, or a lot of you, can picture a high school female athlete. It's almost that like baby giraffe look, which I was labeled as when I was in high school. So it's no offense to those athletes. But that is not protective of the knee. So that is something that in my own personal recovery from ACL surgery, I had to work really hard on training that out of me. And so I would think for a coach, that's kind of the thing that I would say, that's what you would look out for, right? If you see that maybe taller, more gangly athlete who's really has that knee inward kind of buckling or caving motion, that would be something where that athlete could probably really benefit from jump landing training and likely hamstring strengthening and overall just strength training, cross training.
This is a good question here that came in. Let me put myself back on screen so you can see exactly what voice where the voice is coming from. But do you feel that there is any optimal age to begin dynamic valgus retraining?
I don't think you can do it too soon. I mean, it's certainly common for our like younger kids to have some kind of what we call physiologic valgus, but certainly anyone who's in like the middle school, 6th grade and up sport range, no, I don't think that I can think of a reason why it would be too early to start that.
All right, and then looks like possibly our last question of the night. We'll see if another one comes in, but more of a general question. Is there any advice you would like to give to female athletes, their families, or coaches who are concerned about knee injury risks?
Yeah. I mean, I guess what I would say is I would recommend the addition of cross training. And I think that is sometimes a big ask when our high school athletes right now are already in somewhat of a time crunch. They may be involved in multiple sports, which is great, by the way. I think sport specialization has clearly shown some, increased risk of overuse injuries. So multiple sports is great. And they may be in a club sport. So you might be talking about multiple practices in a single evening. It's difficult to add to that. But I don't, at least in my experience, I haven't seen our high school programs be amazing at cross-training and strengthening. So I think if you're somebody who's really serious about, trying to decrease your risk and increase your performance, I think some guided cross-training and strengthening is something that you would never regret adding to your regimen. So if you can find the time and the ability to do so, I think that that is something that's great. And I think for high school athletes, it's really nice to have some guidance, at least as they're getting started on that. So that's where, again, like some of our partners, I think are really great. It doesn't always have to be like a formal physical therapist for some of these things, but if there's, the ability for people to meet up with, some of the experts at, Synergy or places like that, that can be awesome. If the athletic trainers at the schools have the ability to do some of that in a little bit more of a supervised method with patients, or excuse me, with athletes, I think that's really good too. So that would probably be some of my biggest advice, because again, there's lots of these risk factors that we can't modify. That's kind of the one area that we can.
All right, we did have another question pop up, so we want to make sure we get to as many questions as possible. So do you have an opinion on the Bear method for ACL, and I'm going to guess the others
reconstruction?
Yeah. I'm not clinical, but go ahead.
Yeah. So Martha Murray, who essentially invented the Bear method, is very smart. I've gone to a whole research presentation that she put on. I think it's promising. The problem is that I do think that there are specific tears that are more amenable to it than others, right? So you're talking about more of your femoral avulsions. A lot of the tears that we see in these young athletes are not femoral avulsions. The problem that I have with it is that there's some reasonable literature for the Bear method, and maybe slightly faster recovery, because again, you're not waiting for the body to incorporate a new graft. You're having healing happen of the native ACL. So for anyone out there who doesn't know, the Bear method is essentially using this kind of very specialized clot-like sponge material to stick those two ends of the ACL in and kind of create a healing environment to try to heal the ACL, to heal the native ACL. My only problem with the literature on the Bear method is that it's comparing the Bear patients to hamstring ACLs. And the Moon literature shows us that hamstrings do have a slightly higher failure rate as compared to what we're now considering our gold standard, which is BT Bear quad. So in my opinion, I'm not ready to jump on to the Bear procedure yet, because I don't think that we have literature that shows us that it's better than what we're doing to decrease the failure rate. So, what some of my mentors and surgeons that I know are doing is on a case-by-case basis in a patient who is very interested in that, they might offer it, but I don't know many people who are adopting that more wide scale yet, because I think the literature hasn't quite shown us that it's better than what we're already doing to care for these patients. So the last thing I want to do, even though theoretically you can get these patients back a little bit quicker than a standard ACL reconstruction, the last thing I would want to do is a surgery that fails. And I don't think the failure rate yet is lower than our standard procedures. So I'm not jumping onto those yet, but I'm going to continue to watch them, because like I said, I think Martha Murray is a amazingly smart doctor and scientist. And so I'll continue to look out for what's going on with those, how they're doing. And it's certainly something that I'd be open to incorporating in my practice once I have a little more information on it. Now, that kind of brings up a whole separate topic, which again could be a whole nother webinar. But with decreasing re-tear rates in ACLs, the addition of a lateral extra-articular tenodesis does have some pretty impressive literature out there on decreasing re-tear rates in our high school athletes. And so again, in those people with some hyperextension maybe in their contralateral knee, that is something that I'm incorporating in my practice. I just did one last week on a high school volleyball player. So that's something that I would have a discussion about, and I don't necessarily force that by any means on anyone, but if I think somebody's at a slightly higher risk because of some hyperlaxity, I think we do have some good literature that says that might decrease re-tear rates. And so it's a relatively minimal additional surgical procedure. It is an additional incision, but I do offer that to athletes. And I have had, more and more patients that have wanted to go with that. And so that is something that I'm more routinely incorporating in my practice to decrease re-tear rates.
Great. Well, thank you, Dr. DeBruin. I think that
Is there anyone hanging on?
Just wrapping up then for tonight, thank you to all who attended and the great questions that we got as well. I hope you found this valuable. And if you have any suggestions for future topics, you can please go ahead and reach out to us and definitely provide that feedback. Just as a reminder, though, the recording of this presentation will be made available on our website at osmsgb.com/webinars on Friday. And then you can watch and watch the playback if you'd like to as well. If you have, if you'd like to schedule an appointment with Dr. DeBruin or any of her colleagues, you can certainly do so by calling 920-430-8113 or online at osmsgb.com. Thank you again for joining and have a great night.